So this morning, I think what I'll talk to you about is to give you a broad sense, a broad overview of how to look at a chest X-ray. And rather than going through the million different diagnoses that we can see by chest X-ray, I really want to focus on some patterns and some common findings that we all see very frequently on the X-ray, so that you have sort of a way of going through systematically, so that you'll be correct in making your diagnosis about 75% of the time. And throughout the course of this talk, I'll give you patterns that'll get you the diagnosis about 75%. I think that's a good thing to shoot for. We'll go over things with the radiologist oftentimes when we're unsure, but to give you a differential that'll get you there most of the time is what we'll focus on this morning. And I think in starting with looking at patterns, we oftentimes think of distributions. And with a chest X-ray, an infiltrate or a shadow or what have you can be distributed either in the upper lung fields, the lower lung fields. It can be a unilateral process or a bilateral process. And I'll show you a differential for each one of these things as we go through this talk. This is a normal chest X-ray, okay? And this is outlining normal structures here. Number 1 is the trachea. Number 2 is the right mainstem bronchus. Number 3, left mainstem bronchus. You see 4, which is the left pulmonary artery. 5 is a pulmonary vein leading back into the left atrium. Number 6 right here is the right pulmonary artery. I don't see a number 7 on here. 7 is a lower pulmonary vein leading back to the left atrium as well. 8 is the knob of the aorta, and 9 is the superior vena cava, okay, coming back into the right atrium. This is a lateral. Again, a normal X-ray with structures outlined. 1, again, trachea. 2, remember that's the right mainstem, much more vertical than the left mainstem. And this hole, this eye that looks right out at you at the lateral, is the takeoff to the left upper lobe. Okay, this is normal. Okay. Number 4 is the right pulmonary artery. We'll skip down to number 6. Number 4 is the left pulmonary artery, always higher than the right pulmonary artery. And number 7, a vein going back to the left atrium again. And number 8, again, the knob, the arch of the aorta right there. And 9, superior vena cava. You always get this line here, down here on the lateral, and that's the inferior vena cava. So it's important in your mind to sort of commit this to memory, because when you look at a lateral, at least when I started to look at them in the beginning, it was very difficult. But if you have this systematic process and this image committed to memory, it makes it much easier to remember. So when we talk about characteristics of shadows or processes going on in the chest X-ray, we can talk about masses or nodules or infiltrates. And those are really the things I'm going to focus on today. We'll go over what constitutes a mass or a nodule. And then we'll go over infiltrates. And these can be either alveolar, so things that fill the air sacs, or interstitial processes, things that infiltrate the interstitial space in the parenchyma of the lung. You can have a mixed process. And then we can have sort of an end stage a process, or honeycombing. That word you may see on the boards, and we'll go over some X-rays that demonstrate that. So a nodule is defined as a solitary lesion less than 4 centimeters in diameter, and a mass is defined as that greater than 4 centimeters. And the importance of this is that if you see an X-ray with a mass, so a lesion greater than 4 centimeters, there's a very high likelihood of this being cancer. Okay, more than 75% of the time, these will be malignant lesions. Very rarely, though, the other 25%, the three things that can cause masses, so a lesion greater than 4 centimeters, are fibromas, sarcomas, and then the lesions of progressive massive fibrosis in a patient with silicosis. Okay? There's one other thing that can cause that, and that's a hamartoma. Okay, so three things and then the association with silicosis. So fibromas, sarcomas, hamartomas, and the lesions of progressive massive fibrosis associated with silicosis. This is a chest x-ray of a gentleman who lives on the eastern shore here. And if you look closely down here in the right lower lobe, you see this 2-centimeter lesion with a central density. Okay, this is a bullseye or target lesion. And the importance of this is it's small, less than 4 centimeters, not likely malignant. But this pattern here, this bullseye or target pattern, really suggests a benign process. And this is a patient with histoplasmosis. So this was just an isolated histoplasmoma, and nothing should be done further about this. This patient, however, has this left lower lobe process. Okay, this is greater than 4 centimeters. It's a mass, and if you look here at the angle that this mass forms with the pleura, okay, that's an acute angle. Okay, so that angle is less than 90 degrees, suggesting that this is an interparenchymal process. So this is not involving the pleura. This is inside the lung. And you would guess that this is a malignant process. However, remembering the differential for the masses and non-malignant processes, this is actually a hamartoma. Okay? And you can see little scatterings of calcifications in there, which may point you in that direction. Okay? So the important thing is large masses, cancer, except in those rare instances that you see fibromas, sarcomas, hamartomas, and silicosis. This is a patient with multiple lesions with fluffy infiltrates around them, okay? Not discrete masses. And the importance of this x-ray here is this is the minor fissure on the right side. And we have this blossoming infiltrate or mass or shadow above that minor fissure in the right upper lobe here. This is the rising sun or setting sun sign. And the reason that this is important, because even though these things are big, even though these infiltrates and masses are big, this one respects the fissure. And malignancy usually does not respect fissures. Okay, it will cross a fissure. And this sign here tells us that this is probably a benign process. And this is a patient with this is a patient with nodular sarcoidosis. Okay, that has progressed to the point of being very diffuse and large lesions all over. This is a common board question. Okay, this is a large mass that does not have that acute angle sign that we saw before. This angle is more than 90 degrees, so an obtuse angle. That suggests that this process is involving the pleura, either peripherally, which it would show up if the mass was peripheral here, or in the mediastinum, like this mass is. This, if I had the lateral, we would see that this is an anterior mediastinal mass. And this is a young person with a thymoma that's grown. And remember that anterior mediastinal masses are the terrible T's, right? So thymomas, teratomas, T-cell lymphomas, those sorts of things. And this just happens to be a patient with a thymoma, okay? This x-ray right here, we lose the left hemidiaphragm, and it looks like there's a whiteout in the left lower lobe. And the differential for a whiteout is fluid. This could be a pleural effusion, could be a big mass, or it could be a consolidation. And what this patient had was an 11-pound fibroma that was removed from the left chest there, and all of this giant area right here is just a big mass, not malignant, and one of those things that I mentioned that weren't malignancies, fibromas or sarcomas, and this just happened to be an 11-pound fibroma that was removed. So I'll move on now to airspace disease, and this is just a diagram of a normal airway here. We have the major airway leading to peripheral air spaces. Those are connected by these pores of cone, okay? And what happens in airspace disease is something fills up these air spaces, these air sacs. And usually there's spillage over to adjacent air sacs, and this can be caused by a number of things, okay? But there are only 6 categories of processes that can cause airspace disease. And I think if you remember these 6 things, you probably won't be wrong in making your diagnosis looking at an airspace or alveolar filling process. These alveolar infiltrates can be caused by alveolar air sacs filled with water, with blood, with cells, with pus, with protein, or with calcium. Okay? This just happens to be a right upper lobe infiltrate. Okay, this was a patient, an alcoholic who was found down. Okay, and this right upper lobe infiltrate happened to be a Klebsiella pneumonia. So this is classic for Klebsiella pneumonia, alveolar filling process of the right upper lobe. And what was filling the air sacs in this patient was pus. Okay, this patient again presented with several weeks of cough, sputum production, fever. This chest x-ray shows this right upper lobe infiltrate. We see an air bronchogram going through there. Okay. We know there are 3 segments of the right upper lobe, and this just happens to be a posterior segment of the right upper lobe pneumonia, okay, in a patient with cough, fever, and sputum. Similar to that, this woman presented with about a year's worth of cough. No fevers, no real sputum production. We see this soft alveolar filling process in the right upper lobe here with an air bronchogram maybe going through there. And this person actually had bronchoalveolar cell carcinoma. So it's important to remember that the air sacs can fill with pus, but they can also fill with cells. And this would be a cancerous filling process, alveolar cell carcinoma. As opposed to alveolar filling processes, we also have processes that fill in the interstitium, the parenchyma, problems that infiltrate the lung and not the air sacs themselves. Again, this is the cartoon showing the airway, air spaces, pores, interstitial space here. And what we see is in an interstitial process, this parenchyma, this interstitium, gets thickened. Okay, and there are many, 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 many things that can cause this. Hundreds of things. The important point here is that if we think about how we're going to describe and if we think about where these infiltrates are located, it may give us a better differential and a better idea, better guess as to what is causing these things. Interstitial infiltrates can be reticular, they can be nodular, they can be reticulonodular, they can be end-stage or honeycombing, or they can be ground glass. We'll hear more in the next lecture on honeycombing and ground glass by Dr. Horton. I'm going to focus more on the reticular and nodular and the combined processes here for interstitial infiltrates. This is an X-ray of a young man with these little dots everywhere. Okay, this is a diffuse process involving both the upper lobes and the lower lobes. It's a nodular process. You see these little nodules over here. And the key thing with this x-ray is this could be anything. This could be one of 150 things. This just happens to be varicella pneumonia. And unless we can figure out a systematic way of looking at this, there's no way you could make the diagnosis from this x-ray by itself. This is a second x-ray, looks very similar to that which I showed. Little nodules everywhere. This just happens to be nodular sarcoid. So again, unless we can figure out a way to characterize or classify these infiltrates, there's no way that you're going to make a diagnosis by the chest x-ray. So what we have here is a simple list of interstitial processes which involve both lungs and only the upper lobes. Okay? And the mnemonic here is Aztecs. Okay, spelled wrong, but Aztecs. Okay? Ankylosing spondylitis. Okay, that usually is when it affects the lungs, will be bilateral. It'll show reticular, linear opacities in the upper lung fields, usually in a man. Sarcoid is a disease predominantly when it involves the interstitium of the lungs, an upper lung process. Tuberculosis, eosinophilic granulomatosis, cystic fibrosis, and silicosis. Okay, so commit that mnemonic to memory, and then you'll be correct 75% of the time. Okay. Here is an X-ray which shows predominantly upper lobe infiltrates here. And you can see bronchiectasis, tram tracking, these large airways here. And on the right, this cystic space up here in the upper lobe here. Now, if we use our mnemonic, it's one of those 5 things. This just happens to be fibrocystic sarcoid. Okay? As opposed to this patient here, who again, bilateral upper lobe infiltrates, bronchiectasis, cystic spaces here. This happens to be a patient with cystic fibrosis. Okay? You'll get that from the history, but if you look at the chest X-ray and use the mnemonic, it will help you out. Now, jumping back to these 2 X-rays, we do notice that there's a significant amount of hyperinflation. The rib spaces are far apart. The diaphragm, at least this left one here, and both of these diaphragm are relatively flat. So there is a differential for interstitial disease and hyperinflation. So if you see an X-ray on the boards and there's interstitial disease and hyperinflation, because most interstitial disease causes restriction, small lungs. But if you see big lungs and interstitial disease, you should think of one of these 7 things. CF, we just saw an X-ray of that. Diffuse panbronchiolitis, which is very similar to cystic fibrosis. It was seen predominantly in Japan, treated with macrolide antibiotics. That probably would not be a question you'd be asked on the boards. Eosinophilic granulomatosis, lymphangioliomyomatosis that Dr. Wise showed pictures of, familial dysautonomia, something I would never be able to recognize, but it is on the differential. Neurofibromatosis can cause interstitial disease and emphysema, and then sarcoid, which we just saw. Now, we talked about upper lobe disease. Now, the differential or the mnemonic for bilateral lower lobe interstitial disease is badass. Okay, this has been passed down over the years, and it's bronchiectasis, aspiration, dermatomyositis or polymyositis, asbestosis, scleroderma, and the other connective tissue diseases, sarcoid, and then this early Hammond-Rich, which is an acute form of idiopathic pulmonary fibrosis. Okay, badass. This is a patient, we see bilateral lower lobe lines, okay? Interstitial disease. There's no calcification on the diaphragm, no calcification on the pleura, which would point us towards asbestos. This just happens to be a 60-year-old man with progressive shortness of breath over the course of several years with idiopathic pulmonary fibrosis. Okay, again, remember that that mnemonic, badass. When we see upper lobe disease that's only on one side, we really have to think about infections and cancer. And the infections that do that are tuberculosis, histo, cocci, Klebsiella pneumonia. Remember I showed that x-ray before? That's a classic board question in a patient who may have passed out and aspirated. And then lung cancer. Okay? Those few things, infection and cancer. This happens to be a man with sputum production, cough, high fevers, and sweats. And this is tuberculous pneumonia here. Right upper lobe, infiltrate, and interstitial process, classic for TB. This x-ray, we see a right upper lobe cavity, okay? This wall is thin. It's not surrounded by fluffiness, which would suggest infection. And this happens to be a squamous cell carcinoma, okay? Bronchogenic carcinoma, squamous type. And that's classic, the classic bronchogenic carcinoma that would cavitate. Okay, so we see a cavity, fluid inside that, a meniscus sign, squamous cell carcinoma. Again, we see a right upper lobe process. This is what's called the reverse S sign. Okay, see this backward S? That's the minor fissure being pulled up because of atelectasis and collapse, and this large lesion in the right upper lobe here, which again was squamous cell carcinoma. When we talk about lung collapse, we use the word atelectasis, and the things that can cause that, you can either have something inside the airway, which leads to collapse of that main airway leading to the alveolar space, or you can have extrinsic compression. And the end point of that is that no air goes into the alveolar spaces. The air that is in there is resorbed, and the lung collapses. Any segment in the lung can collapse, and there are a few patterns that are probably important to recognize on the x-ray, and I'll show you those. This is a gentleman with a right upper lobe atelectasis. You see the left upper lobe is nice and aerated up here. We have this infiltrate right here, and the minor fissure, which normally is down in this area, is pulled up, and we have atelectasis of the entire right upper lobe. In this patient, we lose the left hemidiaphragm. The heart border gets straight. We lose the aorta that you can usually see down behind the heart here. And this is a patient with left lower lobe atelectasis. Normally we see on x-ray a very sharp right heart border. This is a person with right middle lobe atelectasis. When we look at the lateral, you can see this nice infiltrate here in the middle lobe. It's not complete atelectasis of the middle lobe because we do see some air going in, but at least one segment of the middle lobe is probably collapsed. And then this is a classic x-ray of left upper lobe collapse. What you see here is this fuzzy area in a straight line. This is the left upper lobe sort of coming out at you and collapsing. And in general, this is caused by one thing and one thing alone, and it's usually cancer. Okay, either intrinsic a malignancy or mass inside the airway causing collapse, or extrinsic compression of the left upper lobe bronchus. And this is a classic X-ray of left upper lobe atelectasis collapse. And then finally, this patient has an infiltrate in the right lower lung zone. And we see the right heart border fine, okay? So it's likely not going to be the right middle lobe. And the only thing left down there is the right lower lobe. So this is a subsegment of the right lower lobe that has atelectasis, okay? Probably the medial segment of the right lower lobe. Moving on to pleural effusions, okay? Some key points here are, if you have a bilateral effusion, okay, and a big heart, the diagnosis likely is congestive heart failure, okay? If you have a normal-sized heart, bilateral effusion, think of cancer or connective tissue diseases, okay? If the effusion is only on one side and large, it's only one of a few things: tumor, tuberculosis, trauma, or an hepatic hydrothorax. If it's small, anything goes. I can't help you there. Okay? So, big effusion, one side, tumor, TB, trauma, hepatic hydrothorax. Large right-sided pleural effusion here. This is a patient with an hepatic hydrothorax. Okay? In general, if effusions are only seen on the right side, we think of congestive heart failure, hepatic hydrothorax, like I just showed you, and then a rare condition affecting women called Meigs syndrome. If the effusion is on the left side, some weird things that can present that way are aortic dissection, esophageal rupture or Boerhaave syndrome, splenic infarct, and pancreatitis. All those things can present as left-sided effusions. This is a patient with shortness of breath. This X-ray showing a haziness on the left side here. We lose the left hemidiaphragm. Comparing the lower lobes together, much hazier on this side. And when we look at the lateral, we see this nice meniscus here, and this is a left-sided pleural effusion, small, in a patient with a splenic infarct. Okay, so just one of those things to remember when we see a left-sided effusion. And here are some other patterns that can present by X-ray. This is a young woman who had a chest X-ray, was relatively normal in August of 1972. About 6 months later, she had another X-ray after she was diagnosed with breast cancer and had progressive indolent shortness of breath. And what we see here is we see all these lines extending out to the periphery. These are actually Curley's A lines, okay, extending from the hilum, parallel lines out, as opposed to Curley B lines, which are lymphatic sort of in the periphery that we see in congestive heart failure. And this is a classic X-ray for lymphangitic spread of her breast cancer. And what we see here is these parallel lines extending out from the hilum into the periphery. Curley's A lines, lymphangitic spread. This was a question that was on both my internal medicine boards and my pulmonary boards here. This is a young patient with sarcoidosis, okay, who has a few weeks of hemoptysis. And when we look at the X-ray here, we see 1, 2, 3 nodules here. This one might be a mass in the left upper lobe. And the key here is that you see this ring around it, This is called a crescent sign. In a patient with fibrocystic sarcoid, these are aspergillomas, okay? And in sarcoid, fibrocystic sarcoid, and old tuberculosis with some cavitation, these are fairly common, okay? And the key here to remember is the crescent sign and this mass or nodule inside the old cavity, okay? Aspergilloma. This is a common pattern that we may see as well. Bilateral, big, huge hilar adenopathy. This is a patient with stage 1 sarcoidosis, okay? Bilateral, symmetric hilar adenopathy. And then this patient was a dental worker, okay, who was exposed to silica dust. And what we see here are these very discrete, nicely outlined, calcified lesions. This is eggshell calcification of silicosis. And this is a classic X-ray of someone with silicosis, an eggshell calcification. And then finally, this is a man with some emphysema, predominantly bullous disease in the upper lungs here. You can see these thin-walled bullae outlined nicely in the upper lungs here, who developed fever, shortness of breath, cough, sputum production, and the way this was billed was a lung abscess. He had pneumonia here in the right upper lobe, but what happened was one of the bullae filled up with fluid, and this isn't really an abscess, it's just an effusion or fluid collection that filled one of the bullous lesions. He was treated with antibiotics, and all these resolved. Okay, so the important thing here is that we had an X-ray from before, and we see that all this bullous disease was present, and when infection presented itself, we now see it filled up with fluid. So I think with that, I'm going to stop here and wish you the best of luck. I can answer any questions